Chapter 25 concerns the neurological assessment. So, the neurological system consists of the central nervous system and the uh, peripheral nervous system and the autonomic nervous system. There's several divisions. Uh, the central nervous system consists of the brain and spinal column, and the brain has several parts as well. The cerebrum has a variety of functions, which we'll get to in a minute. And then the diencephalon consists of thalamus and hypothalamus. It's directly under the brain. It's a relay station, and the hypothalamus regulates things like temperature, appetite, thirst, sleep cycles, pain perception, and the like. Then the cerebellum is concerned with coordination. It does not have any consciousness, but the cerebellum coordinates muscle movements. It smooths out the muscle movements, where if you didn't have a cerebellum, your movement would be uncoordinated and very jerky. Also helps with balance, muscle tone. Then the brain stem, it regulates breathing and heart rate, blood pressure, and it's also a relay station for the cranial nerves. The spinal cord itself contains ascending or afferent and sensory tracts, and descending, which are efferent or motor tracts. And then these tracts are going to transmit sensory and motor impulses, and also some feedback is processed in the spinal cord as spinal reflexes without having to go to the brain. The cerebral hemispheres, the frontal hemispheres control mental function, everything we think of as consciousness, judgment, reasoning, voluntary activities, communication, emotion, all that. Then the temporal areas has the hearing center, and it has Wernicke's area. So Wernicke's aphasia is a problem that that would be connected with the temporal area. The parietal area is primarily concerned with tactile sensation, and the occipital area has the visual center and also controls reading ability. The spinal cord, anatomically, we see an anterior and posterior horn on each side. And then there are ascending pathways. Those are the ones that are going to bring sensation to the brain. Those are the two main ones are the spinothalamic tract and then the posterior columns. And then the descending pathways, there's pyramidal and extrapyramidal tracts. Then as far as peripheral nerves, we have the nervous system. We have cranial nerves. They begin in the central nervous system, and they go directly out to their target areas without going through the spinal cord at all. We also have spinal nerves. And then we have the autonomic nervous system, and that has two parts as well. Sympathetic, which is flight or fight, and that one is primarily controlled by the nerve roots from T1 to L2. And then the parasympathetic one is controlled by the nerve roots from S1 to S4 and cranial nerves 3, 6, 9, and 10. So as always, we begin with the history of the present concern. And you, of course, do cold spa on anything that the patient complains of. Uh, Headaches, which could be, many times headaches are just a trivial problem that doesn't really matter, but in the neuro assessment, sometimes a headache can be a symptom of something much more serious, such as even a brain tumor or something. So that would be an important symptom to follow up on. Seizures, you'd want to know what type of seizures. Some people can tell you their type, but if they can't, why then you'd ask them, well, do you lose consciousness when you have a seizure? Do you lose control of your bladder? Do you have a sensation that lets you know you're going to have a seizure? Those kind of questions. Dizziness. And there are two types of dizziness as well. There is what we call objective or subjective, and subjective meaning that you feel like you're spinning, and objective you feel like the world is spinning. Numbness, which could also be tingling or could be a sign of neuropathy. Any problems with sensory abilities, whether it be smell, taste, hearing, vision, feeling, maybe loss of feeling, some aspects of feeling. Tinnitus, that's a sensation of ringing in the ears. And visual changes, which could be double vision, maybe narrowing of the vision, those kind of problems. Difficulty speaking or swallowing. Any difficulty speaking or swallowing. A change in bladder or bowel control as well. Sometimes that's just a urological problem, but it can also be a central nervous system problem as well, or a peripheral nervous system problem. Muscle weakness, loss of movement, any repetitive involuntary trembling, and memory loss. That one you'd probably have to ask a relative or surrogate about, because the person themselves would probably not be aware of it. Sometimes they are. Sometimes they can tell you they've been having more trouble remembering things lately. Now, as far as history, we want to know about head injuries, whether or not they had loss of consciousness, and that's important to ask too. If they had one, the next question is, well, did you lose consciousness? Then any history of meningitis or encephalitis, any history of injury to the spinal cord, strokes or TIAs, and then family history of either hypertension, stroke, Alzheimer's, dementia, brain cancer. Huntington's chorea is a disease that's only manifested in women, and if the woman is going to get it, it usually hits around age 30 or so, and it's characterized by a severe lack of coordination and motor control. The person makes extreme exaggerated movements and would become unable to feed herself, for example, because when trying to get the spoon to the mouth, the spoon tosses the food off on the floor. And this is a hereditary problem, but it manifests in women and not in the men. Lifestyle and health practices. We'd be particularly concerned with illegal drugs here. Medications, but also drugs such as the ones that are listed. And then, of course, our alcohol and tobacco. And then we also would want to know about if they regularly use seat belts in the car or protective headgear as a motorcycle rider. And we'd want to know about their diet. We'd pay particular attention to if they might have a deficiency of B vitamins. The B vitamins are, if you're deficient in B vitamins, that can end up causing neurological symptoms. And besides having a deficiency, if you drink a lot of alcohol, why then you're going, even if you get adequate B vitamins in the diet, they won't be properly absorbed or properly utilized, and so you will probably end up with a deficiency of those B vitamins anyway if you have alcohol. And that's a big part of the symptom when you have alcohol withdrawal symptoms. Some of that is manifestations of the B vitamin deficiency, and by giving B vitamins IV we can help ameliorate some of that. Then exposure to certain toxins will have neurological symptoms as well, such as lead, insecticides, some pollutants, other chemicals. One time I was doing some painting and I spilled paint on the carpet and I wanted to get it out, and so I got a paint removing chemical, and I read, well, it says to wear gloves, but I say, oh, I don't have any gloves, I'm just gonna put it on paper towels and use it. And after I finished doing that cleaning, I noticed that I felt horrible, and I had to lay down, and I had a headache. I felt really bad, and it turned out what happened was I absorbed some of those chemicals through my skin. So another example of what not to do, where read the directions and follow them. Lifestyle and health practices continued. We want to ask about heavy lifting, because that can lead to spinal cord problems. About any ability, what are IADLs? That's instrumental activities of daily living. We want to know about their ADLs, activities of daily living ability as well, but activities of daily living are things like feeding, bathing, dressing, walking, transferring from bed to a chair, that kind of thing. The IADLs, instrumental activities of daily living, are things that pertain to your self-care, but they're more more broad level, like cooking, doing the laundry, using a phone, managing your money, those kind of things. So they're self-care, but a little more extended. Change in your self-concept, and then of course stress. So to begin with the objective assessment, we assess the cranial nerves, and you can do this in a very quick way, but when you're first learning it, it will take a long time. After you've learned it well, you can assess them fairly quickly. Commonly, there's a few that we commonly don't assess unless there's a reason to suspect there's a problem, because they're very rare to have problems with. The olfactory one is one of those. Some people that have motorcycle injuries without a helmet and hit their heads right above the nose may have olfactory nerve damage. So that would be one time when you would probably want to assess it, but unfortunately the patient would probably be comatose too. But if they weren't, or when they came back out of the coma, you might want to assess that olfactory nerve function. And the way we do it, we just occlude one nostril and then the other. And each time we offer a scent that's a little bit of oil on a cotton ball and see if they can tell us what the scent is. Sometimes when you're doing it in a quick way, somewhere you don't have those oils, you can use things like maybe coffee or don't use anything that's don't use something like ammonia that's irritating or noxious. Then the second one is the optic nerve, and if the person can see, why, we know that it's grossly intact, but we might also assess visual fields because the vision, of course, there can be a lesion somewhere along there, so maybe one of the quadrants would be affected and other quadrants are not. So we do a little bit more than just see if they can see on both sides. We also test visual fields, and you'll see how to do that in the lab. That involves testing their peripheral vision. And then we take the ophthalmoscope and we test for the red reflex first, then look at the retina and the optic disc and see if there's any bulging of that optic nerve in the there, where we can see like the tip of it directly. Then we're going to test cranial nerves 3, 4, and 6 all together. These ones move the eyes side to side, up and down, and diagonally. So we test all the eye movements and see if those are all intact. If they're not, it could be a problem with one of these nerves. It could also be a problem with the muscles, that a weakness of the muscles that control those movements. So that would be something you'd probably have to refer to either a neurologist or an ophthalmologist. We also test pupil reaction, and there's 3 different pupil reactions, which don't confuse them. The direct response means I shine a light in your eye, and that eye the pupil constricts. The consensual response is I shine a light in one of your eyes, but the other eye constricts. And then the accommodation response is that I cause you to move from focusing on something that's a little far to something that's closer in, and your eyes should constrict to that. So all 3 of those should occur. They're much easier to assess in people with really with blue eyes or green eyes. They're harder. People with dark brown eyes, they're very hard to assess, but you'll see some of the ways we do that in the lab too. Then cranial nerve number 5, the trigeminal nerve, we ask the person to clench her or his teeth, and it has 2 parts. It has a motor part and a sensory part. So to assess the sensory part, we could have them test sharp and dull sensation on the face. You just have the person close her eyes, and then you could take a paper clip maybe, and the bent end is the dull end, and then you straighten it out, and the sharp end would be the sharp. And then ask her to distinguish between those 2 sensations. Then don't do this in the lab, please, but you could test the corneal reflex as well. That would probably be mostly done on people that are unconscious, but you would let the cotton, let a wisp of cotton lightly strike the cornea or stroke against the cornea and see if they blink in response. But don't do that on your partners, please. Then cranial nerve 7, the facial nerve, we're going to have them smile. See if their smile looks symmetrical. Have them raise their eyebrows, show their teeth. And then the sensory part of that one will see if they can taste, put like maybe sugar, salt, sour, or bitter on a tongue blade and let them taste it and tell, and then they can describe the taste. Then 8, cranial nerve 8 is acoustic and vestibulocochlear. So the acoustic part, the nerve itself does two things. It conducts hearing to the brain, and it also the sensation of balance. So for the acoustic part, we do the whisper test, which will start with we whisper occlude an ear, and then whisper a 2-syllable phrase, and then you test the other ear following that, and they should be able to repeat those 2-syllable phrases for you. And you would want to start with the better ear with that. So you would have them occlude their ear that has the worst hearing first. Then the Romberg test. If you do this on somebody, be sure that you're ready to catch them in case they fall, where you would have them standing and ask them to close their eyes, and you observe for swaying or repositioning, or maybe even actually falling. So like I say, you need to be prepared to catch them if they start to fall. 9 and 10 we're going to test together, the glossopharyngeal and vagus, and we ask the person to say ah, and then use the tongue blade to try and stimulate a little gagging. It should not be hard at all to stimulate gagging. If you can't, then that indicates a possible problem there. Or the other thing that might indicate a problem would be if the uvula deviates to one side or the other. And then the other thing we can do is a swallow test. You can give them a small amount of water, like maybe 5 milliliters, and see if they're able to swallow that, or if they're hoarse afterwards. Then cranial nerve 11, the spinal accessory. Just ask them to shrug shoulders while you put resistance to feel how strong the action is. And then number 12, the hypoglossal, assess the strength of tongue movement. You can feel it through the cheek. You don't have to actually, or you can use a tongue blade against the tongue and have them pushing against that. So then we're going to assess the cerebellar systems here, and the motor systems as well. First, look at the muscle groups, the major muscle groups. Do you notice any wasting away? Like somebody that has had hemiparesis, say, where they've got a paralysis and they've had it for a while, those muscles will be smaller. They'll be visibly smaller than the muscles on the side that they still have the use of. Hemiparesis means you have a paralysis that's one-sided, or not necessarily paralysis, it can be weakness, but so on the side that's affected, after a while you'll see some muscle wasting. Then you'd want to assess the strength and tone of the major muscle groups, and look for unusual involuntary movements like tremors. And the tremor can be, sometimes the tremor is intentional, meaning that you don't see it when they're at rest, but you do see it when they try to make a movement. Then assess gait and balance, and there are various ways we do that. We just have them walk and watch their walking. Then we ask them to do tandem walking, where they do heel to toe, heel to toe. Then walking just on the heels, walking just on the toes. And then we're going to do the Romberg test, which is just asking them to close their eyes. We already talked about that. Be sure, ask them to hold their balance while they're closing their eyes, and observe for the swaying and the like, and be sure to be ready to catch them. Then you can do finger to nose, ask them to touch their nose, then ask them to touch your finger. Then you start moving your finger around a little bit to make it harder, see if they're able to keep up. Have them do rapid alternating movements. Then have them bring their heel up and down their shin, if they're able to do that in a smooth manner. And then if they're unconscious, you can observe for decorticate and decerebrate posturing. There's a picture at the very end of this chapter. There are pictures of that. There's pictures earlier in the book, like on page 84, I believe, or 89. I can't remember the page, but it shows both the same, and that's wrong. But go by these pictures at the end of chapter 25. There's like a typographical error on the pictures, and the one is earlier in the book. Then as far as testing the sensory system, different sensations are transmitted in different spinal tracts. So if you had a lesion that's only affecting some of those spinal tracts, you could have some sensations intact, but other sensations you wouldn't be able to feel. So that's the importance of testing different sensations. So we do light touch, and then pain, which would be a different tract, and then temperature, and then vibratory sensation. You can take a tuning fork and you stick the end that you're holding. Don't touch the fork itself, but just the round end that is like the stem. Touch that end to the person and see if they can feel vibration. Then sensitivity to position. Ask them to close their eyes, put their toe either up or down, their finger either up or down. Can they discern that? With the vibratory sensation, you usually test the tip of the finger and the tip of the toe, because you know that if it's intact from the most distal places, it's intact on the places in between as well. Then point localization would be if they're able to tell you where you're touching with like a sharp point, like a paper clip, the sharp end of a paper clip, for example. Then graphesthesia, you write a letter asking them to close their eyes, and then write a letter or number and ask if they can tell you what letter or number you wrote. Stereognosis is closely related to that. That's you give them a familiar object with their eyes closed and ask them to identify that object by the sensation. Then two-point discrimination is very interesting. At a certain point, a certain distance, which is going to depend on where on the body you're doing it, and also on the individual, why they're going to feel the 2 points as one. And on the forearm itself, why it can be quite surprisingly far apart. Try this on your partner. Make sure that her or his eyes are closed, and you may be surprised by how far apart. Like you try it with just 1 point, then try it with 2 points. Ask them to tell you which one, and then after they're distinguishing between a real 1 point and 2 points. Then you start moving the 2 points closer, and at a certain distance, why, they're going to feel that as 1 point. And on the back of the hand is much more sensitive. There's a lot more nerve endings in the hand than in the forearm or the thigh, for example. So if you try it on different parts, there will be quite a bit of difference between the distances on those different parts. Then extinction works. The way that works is you have them close their eyes and you're giving them a stimulus like a light touch on one side or the other or both, and then if they just end up feeling the two-sided on one side, like sometimes you'll be able to do it with somebody that has this, like you touch them on the left, they feel it on the left arm, then on the right arm they feel it on the right arm, but when you touch it on both, they just feel it on the right arm. That's an abnormal finding, but in strokes we sometimes see that. So next, deep tendon reflexes. So we'll show you in the lab how all these are done, and I have also included videos where people demo all these different reflexes. When you're testing them, you're actually testing if there's a lesion at different nerve levels, and I've put the nerve levels here for all the various deep tendon reflexes. So since those are described on the demo videos, I won't go into how you actually do them, because it's easier to see it on the video and the directions in your book. And depending on how good your instructor is, I have to tell you, I'm not very good at getting reflexes. I can get ones that are really, people that have really strong reflexes, I can sometimes get them, but somebody that has weak reflexes, I'm not your man for getting those. But some of the instructors are really good at those techniques, so maybe you'll be lucky and your lab instructor will be really good at it. Or maybe you'll be lucky and have a partner that has hyper reflexes. So, tests for meningeal irritation. Before you do these, make sure that you don't suspect any cervical injury, like you would want to rule before you move the neck at all for anything. Make sure that it's not somebody suspected of having any kind of cervical injury. But first, you just assess neck mobility. One sign of meningitis is a stiffening of the neck. And then for Brudzinski's sign, you flex the neck while you're watching hips and knees. And then if the hips and knees flex in response, the patient will probably also complain of pain both in the neck and the hips and knees. That would be positive for the meningeal irritation. And then the Koenig sign, you don't do anything with the neck, but you flex the leg at both the hip and the knee, and then you straighten out the knee, leave it while the hip is still flexed. And so if that's positive, there would be pain and increased resistance when you try to straighten that knee. And then you try it on the other side. So an important part about the assessment is assess risk factors for CVA. That would be subjective, but I didn't deal with it at the time, so I've saved it till now. Some of the risk factors for CVA are hypertension, diabetes, really anything that that will impair your circulation, like any kind of thing that promotes atherosclerosis, clotting, that sort of thing. Also coronary heart disease, cardiomyopathy, congestive heart failure, and atrial fibrillation. That's going to promote clot formation, and in many cases a CVA, some CVAs are hemorrhagic, but some are formed by clots, are caused by clots as well. Smoking, alcohol, and illegal drugs are also risk factors. And then increasing age, male gender, although females have more fatal outcomes, and race, African American race is a risk factor too. And then any personal or family history of CVA or TIA. If you've had one, you're at higher risk for having another one. A brain aneurysm, the way an aneurysm works, it's like if you had your bicycle tire and you start seeing a little ball forming at the rim, and you think, oh, I know this tire's going to blow on me, if I can hope I can get home before it does, and you see that bulging gets bigger and bigger and bigger, and the vessels in the brain do exactly the same thing. You can get an aneurysm, and it can, it doesn't, it's not usually a matter of minutes like it is with your bicycle, but over time that aneurysm gets bigger, and the wall gets weaker until finally it bursts. And then an AVM, that's a arteriovenous malformation in the brain. The most common area is that circle of Willis. Instead of a nice symmetrical neat circle like shown in the anatomy books, you have a tangled mess of our arteries and veins there, and that's called an AVM, an arteriovenous malformation. Other risk factors: sickle cell disease, vasculitis, or bleeding disorders. Anything that affects those vessels is going to promote CVAs or put you at increased risk. Sedentary lifestyle, obesity, stress, depression, diet, especially a diet high in cholesterol or high cholesterol levels in the blood, and prolonged use of non-steroidal anti-inflammatories, except for aspirin. We give aspirin to prevent strokes, and then the exception with that is if you're going to have a hemorrhagic stroke, why aspirin would possibly make it a little worse. Diagnoses. So there are a lot more in the book, but I just picked a few. Risk for injury related to disturbed sensory patterns. So you might think that, oh, it's great not to be able to feel pain. I don't, if I don't feel pain in my arm, that's wonderful. But people that actually lose pain sensation sometimes end up burning their arms severely before they realize what's going on, or are causing other severe damage. So it's not a good thing to have disturbed pain sensation. Risk for aspiration related to impaired gag reflex. That's going to be a very big problem with your stroke patients. And the rule is that until you've assessed their swallowing function, they're going to be NPO. Then impaired verbal communication related to aphasia as evidenced by lack of word finding ability. There's expressive aphasia, meaning that you can't say what you want to say. Receptive aphasia, you can't understand what other people are saying to you. And their global aphasia is both. So the person that just has expressive aphasia can understand quite well. The person with global aphasia can't say what they want to say and they can't understand what you're saying. Now, they may or may not be able to understand other types of communication, such as gestures, written communication, that kind of thing. Impaired swallowing related to absent gag reflex as evidenced by failed swallow test. And so that, like I say, that is fairly common among stroke patients. Then as far as collaborative problems and referrals, increased intracranial pressure. That is something you'll be learning a lot more of in Senior 1 when you get to complex care, the complex care course. And it's a medical emergency. Increased intracranial pressure is a medical emergency that you need to notify the physician right away when you see signs of that. Some of the signs might be a narrowing pulse pressure, rising blood pressure with a narrowing pulse pressure. Remember, that's the systolic minus diastolic is the pulse pressure. So if you see that systolic is going higher, and then that pulse pressure is narrowing and the heart rate is following, that would be a sign that you and then but before you get to that, you'd probably see decreasing level of consciousness, like you're checking the person's level of consciousness every hour, every 2 hours if they're at risk for increased intracranial pressure. And if you see that they were, say, maybe a little confused, but they could tell you who they were, where they were, and the date anyway, and then suddenly they can't. Or maybe they weren't talking at all, but they were moving, and now they would move, and now they are not moving voluntarily. Things like that, changes like that, are things that would indicate that you might have increased intracranial pressure. And sometimes you even monitor it. If they're really high risk, they may have a monitor and where you have an invasive probe and you're monitoring it. Then risk of complications for seizures. If you see a seizure, first you'd want to assure the patient's safety, like, make sure that they're not next to anything that's going to damage them, get away from any danger. You want to have suction equipment available, but you can't leave them, of course, when they first start having the seizure to get that suction equipment. Hopefully you have that set up beforehand. And then you want to time the seizure, observe where it begins, and basically you just monitor them and make sure that they're safe. And then when it's over, you'd report it to the neurologist, and you might expect orders for new medications, or maybe an increase in the dose of the medications they're already on. And then risk of complications for stroke. Again, remember your stroke symptoms, because you might observe a stroke or something you think is going to be a stroke. And remember that acronym FAST: facial asymmetry, arms, one of the arms are unequal, one of them you can raise, the other you can't, speech problems, and then time, meaning that if you think you've got a stroke call 911 if you're outside the hospital. If you're in the hospital, call rapid response, or many hospitals have separate stroke alerts, stroke codes. So yeah, call that right away. Don't if you see those signs, don't second guess and think, well, I'd better call my instructor first, or I'd better, just call the RRT if you think that they're having a stroke. It could turn out to be a TIA, but even that is putting the person at risk for strokes in the future. So don't wait on calling the alert for stroke symptoms. That's the end of this lecture.